All right, so ascites. So ascites is a fluid collection in the peritoneal space, and it's a few reasons. It's most likely because the albumin is low. If the albumin is low, you're not able to hold on to water inside the vascular space, right? So where sodium goes, water goes. Where glucose goes, water goes. Where albumin goes, water goes immediately. It's 70 times more powerful than second place, which is sodium. So sodium pulls it at 1x, let's say, and then albumin pulls it at 70 times that, right? So you can see up there in 480p, you can see up here that water, when albumin says I'm here alone in this vessel, it's going to go right across 70 miles per hour, right? So it's going to eject outside and go from wherever albumin's at. So if albumin is not being made, the fluid is going to be lonely. It's just going to go wherever it's being pushed, which is going to be pushed into the belly. Okay. So I can't read that, so I apologize for the college Wi-Fi. What else do we have here? All right, so albumin, poor serum. We got fluid retention. So all that fluid that we, just like with portal hypertension, all that fluid, same story. All that fluid is being put into the portal circulation. And we put enough fluid into a vessel, some of it will be pushed out by hydrostatic pressure. Right? All that fluid will get pushed out into the belly. That's where the highest highest blood pressure is in the belly. Right? So all that fluid that gets dumped there, it has to go somewhere. It will engorge a little bit, but you are able to push a little bit of fluid out into the belly for ascites. Right? So portal hypertension you usually see also with this. All right. So what else? So you got a cirrhotic liver. You got low albumin happened over here. We got oncotic pressure, that's the pressure to hold stuff where it's at. So the oncotic pressure is low. We can't hold on to water. So the water leaves. And we got the ADH and the RAS situation that are causing more water reabsorption because the blood volume is poor and at the kidneys, and the kidneys are like, well, I need to fix this. So they release, we release the RAS, ADH gets released from the brain, SNS fires off, and that's going to cause more volume to be circulating. And that causes the sodium level to go down or up? Go down, because ADH absorbs water, aldosterone absorbs sodium and water, so therefore we got 2 waters and 1 sodium. All right. So this is the most common complication of cirrhosis. 50% who get diagnosed with cirrhosis will develop it in 10 years, and then after that, they're gonna 50% die every year because of ascites. It causes so many complications what they have. It's a vicious cycle, as we'll point on the next slide about how to fix this. Okay. So there's something you can do to assess ascites. You can turn them on their side, and you can assess tympany. Nobody assesses percussion anymore, but you could do that. You could say, oh, it's dull right here. If I move to the side, it's dull where they're by gravity because all the fluid is pushed to the side, right? There's also a distinguished test you can do where you put one hand on one side and you kind of tap it, right? And then you should be able to feel it on the other side. If they had just bowel, it would just dissipate. But if you have fluid the whole way, it's called a fluid wave test, right? So I'm not sure how you describe that to the patient about what we're going to be doing next, right? All right, so this guy right here is, he's not aggressive enough. He's not smacking that belly as good as he could. Yeah, you do need about 1.5 liters to be able to for ascites to show up. But he's just kind of flicking it. You really want to give it a tap, right? And you can put your hand halfway, you'll be able to feel it there, but on the other side, you'll be able to detect the fluid wave on the other side. Okay, so on the bottom left there describes all the mechanisms we were talking about, if you can read it. So all those mechanisms are used to worsen our ascites. So obviously the medications we give are going to be there to stop that. It's going to stop the aldosterone. We're going to give albumin when we pull out that fluid. We're going to give albumin so we can hide them over, to tie them over to the next paracentesis. Right? So paracentesis is where we're putting a needle into the belly, right, to pull out extra fluid, because all this fluid will put pressure on the kidneys. Now the kidneys get damaged, right? All right, so you can tap it, but you don't want to be, grabbing your redneck friend.
Whoa, black Betty, bam, damn, whoa, black Betty, bam, damn, the black Betty had a child, bam, damn, the damn thing gone wild, bam, damn, whoa.
All right. So this is one of my past students down here. Still got to study. All right, so how do you treat ascites? How do they fix it? There we go. So diuretics. So we give spironolactone. If you remember from Med-Surg 1, spironolactone is an aldosterone inhibitor, right? Inhibit aldosterone, we're not going to have all that extra fluid reabsorption, right? That's one of the problems, is that we're reabsorbing too much fluid. So spironolactone is going to block that RAS system, so we are not going to cause a reabsorption of water, and therefore we can reduce our ascites. If that doesn't work, we can add furosemide, which is Lasix, right? But that's just we're trying to pee out the fluid. Hopefully they have a good renal function, right? Sodium restriction. It's a 2-gram sodium diet. So there's no fluid restriction, because if you reduce fluid, now we're back to square one. No fluid, now the RAS and the ADH is going to fire off, and that's going to worsen it, right? They need a high protein diet. They need to make all the albumin they can make, if they can make albumin. But also the high protein diet is recommended for our hepatic encephalopathy patients, which we'll talk about coming up, all right? So it avoids worsening hepatic encephalopathy. So here's our normal albumin right there. We can do pre-albumin, which is a marker of how bad the liver function is, because they do get malnourished with liver failure, because A, they don't want to eat, right? B, their belly's all engorged as well, and they don't have enough building blocks to make albumin in the first place, okay? So the key point here is they do large volume paracentesis. They don't just do like 250 cc's. They pull out a good 5 liters minimum. That's the goal, is to pull out as much fluid per session as possible. And then you replace about 6 to 8 grams of albumin per liter removed. So it's going to hold them over for the next cycle. And usually like the time between paracentesis gets smaller and smaller and smaller. You can see the bottom left there, they get the paracentesis, they get the albumin, and they're back in a week to 2 weeks, right? They have this constant cycle. And then you're constantly poking, you're at risk for infection. The ascites itself puts you at risk for peritonitis, spontaneous bacterial peritonitis, which we'll talk about. So there's a lot of problems that can happen with ascites, okay? So large volume paracentesis, so at least 5 liters. So you can see this guy right here did a good job. They have at least 5 liters. If I can find my cursor here.
This man is suffering from ascites. This is where fluid builds up in the abdominal cavity, usually as a result of liver dysfunction, but cancer can do it too. And what we're going to do here is we're going to drain the fluid with a procedure called a paracentesis. First of all, that blue tarp right there, that's sterile, so that's to keep the area clean. So right now, he's inserting a needle with a rubber tube over it. That tube is the catheter, and that's going to go into the abdominal cavity. First, you would visualize the area with an ultrasound, make sure there's no bowel or anything else that could be damaged. But once you have a good image and you know it's safe to insert the needle, you put that in, and now he's just got that little plastic tube in there. No more needles, so there's no risk of damaging the bowel or any of the intra-abdominal organs. So now what we're going to do is we're going to attach that tube to a vacuum container and then suck out all that fluid. First of all, you would run tests on the fluid if the diagnosis wasn't made to try to figure out what caused it to build up in the first place. Now, look at the size of his abdomen. So look at how distended he is, and it's in fast motion. So you're going to see the belly slowly go down in size, and I can't even imagine the relief this man would feel. When the belly is so distended, not only is it uncomfortable, but it's even hard to breathe. You can't extend your diaphragm down, so he's going to be breathing better, he's going to be lighter, probably 30, 40 pounds lighter. Yeah, look at all that fluid. So probably 40 pounds lighter after this procedure. Now,
Each one of those is a liter?
Yeah. All right, so a lot of fluid is the goal, okay? So do we do a low sodium diet? Yes. Low fluid diet, fluid restriction? No. All right, so it's about 5 days of normal life, and they're constantly going in and out with this process.
And you said the length between paracentesis shortens as
It shortens, yeah.
progresses.
Mm-hmm. Yeah, and they will have complications from the paracentesis or complications because you're pulling all that fluid. Now they become a risk for what? Hypotension, hypovolemia, right? And you got to restore the right amount of albumin. Sometimes they don't even give it, and then you're like, well, why are they hypotensive? 8 hours later, it's because you didn't restore the volume. Okay. All right, so complications. We've got SBP, so spontaneous bacterial peritonitis. So all this fluid right here, do you think there's a lot of white blood cells in that fluid? No, at baseline there is not. And if an infection were to get into there, it goes from the gut to this ascites space. It's like, ooh, this is nice. Look at this. Look at so much room, so much leg room, right? And it can keep proliferating and proliferating and proliferating until a white blood cell even gets inkling that there's a problem, right? Because white blood cells don't routinely patrol that area, right? It's an area that's not, as a false space that wasn't designed to be there, right? So you get a spontaneous bacterial peritonitis because the bacteria can easily translocate and across the bowel wall, and they can make their way into the belly and cause an infection. If you have an infection, that causes a systemic response, and now you're at risk for GI bleed, right? You're also at risk for hepatic encephalopathy, as we'll point out, right? Most common bacteria are bowel bacteria, right? So we got to pull out, and usually when they do the paracentesis, like, oh shoot, why is it all cloudy? It's a sign of SBP, spontaneous bacterial peritonitis. It just happens spontaneously. They could be doing their ascites, the great technique, all of a sudden now it just makes its way across, right? And you got to treat it with antibiotics, and also you give albumin for it. The albumin is going to pull the fluid into the vasculature space so that the white blood cells can actually fight the infection, right? So signs of SBP are P, which is what? Peritonitis, right? They're going to have a abdominal pain, they're going to have some fevers, they're going to have an SNS response, and 70% of patients that get it once will have it again, right? And it's a downward spiral from there because now it could have SBP again, but now you might have a GI bleed this time, and next time you might have hepatic encephalopathy, and next time you might have another infection. So it's a downward spiral. All that fluid from ascites can make its way into the lungs. That's also a complication, right? But basically, when you have all this fluid volume that is decreased, it's going to cause a decreased circulating volume, and therefore the kidneys get upset, and you can get what's called hepatorenal syndrome, right, where the kidneys get involved, which we'll talk about next. Okay, so hepatorenal syndrome is all this hypotension from the albumin poor state to the portal hypertension causing vasodilators to circulate through and all the volume to make its way to the portal circulation and not be where it should be inside the arterial system. All that fluid is going to make its way and cause a decrease in perfusion to the kidneys, right? And of course, patients come to the hospital, they have all kinds of other risk factors. They could have nephrotoxins. What's an example of a nephrotoxin? NSAID's good, and like vancomycin, for instance, is a nephrotoxin. And then was it excessive diarrhea? Because we'll find out how we treat hepatic encephalopathy is with lactulose, which causes diarrhea. So then they have too much diarrhea, now they have decreased circulating volume, and you're now dehydrated, and you're causing kidney damage. They're already high risk for kidney damage to begin with, right? You got a GI bleed, that's a decreased volume. That's getting lost, right? They got volume depleted because of large volume paracentesis and they did not replace the albumin. That's also going to overdo it. Or they're giving diuretics with someone that has ascites, and that can cause excessive fluid volume waste, right? And it can be volume overload. Even being volume overload can is actually more damaging than low volume, right? All that volume inside the belly can push on the kidneys mechanically and cause the kidneys to fail, right? So by the same token, increased intra-abdominal pressure from ascites. We got deterioration of liver function, like you're worsening portal hypertension. That's going to worsen the amount of volume that's circulating around the body. All right. So again, they look at kidney function, and what's kidney function? What lab is that? That's creatinine. They look at the creatinine changes. It's going up. That's a sign that the liver might be causing the creatinine to go up. But this is really a diagnosis of exclusion, meaning that you got to take everything else out of the picture and say that yes, the liver is causing the problem. So usually we support the blood pressure. We give albumin for this, right? So there's 3 things for albumin: hepatorenal. What are the other 2? After a what procedure? After an LVP, large volume paracentesis. And the third thing we give albumin for is SBP, spontaneous bacterial peritonitis, right? So you give it here just to restore blood volume, hopefully, right? And we have other tricks. We give midodrine. Midodrine is an alpha-1 agonist, and it will vasoconstrict and raise the blood pressure to the kidney, hopefully. Okay. Tolvaptan is an ADH blocker. So that ADH blocker to increase sodium, but it doesn't really work that well. But dialysis really is a conversation they have to have, because usually if they're at this point, their liver failure is so bad that if they put on dialysis, they are not going to recover, right? So they usually have to look to rule out all the other things before they put them on dialysis. All right, you can see even hepatorenal is not even on this list here, but you can see the complications that happen and the risks. So 20% chance of dying is it 1 year or 5 years? It's probably 1 year. If you have ascites, right? If you have 57% chance if you have GI bleeding. If you're going to die in 1 year, about 57% chance you will die. Okay, so it's an incredible, all these different complications add up to death, unfortunately, right? It's irreversible unless we have what? A liver transplant, right? And they have to be stable enough for that. There's all these complications can happen before you even get the liver transplant. Hepatic encephalopathy. So by the same token with GI bleeds, how you had a leaky vessel that would cause bleeding, here you have a leaky blood-brain barrier, all right? So with a surge response, same deal. You got a surge response, you have things get leaky. So your vessels get leaky in your esophagus, but also your vessels get leaky at the blood-brain barrier. Also, these proteins that make up the blood-brain barrier are proteins, and proteins come from the liver. So that's also a reason why you might get encephalopathic. You might get symptoms of hepatic encephalopathy. And like we mentioned before, ammonia is a waste product. When you have too many amino acids, they then get combined by the liver into what? Urea, right? And then urea gets excreted where? In the kidneys, right? Urea is a waste product. Blood urea nitrogen is a waste product, right? Why is it called blood urea nitrogen? Because nitrogen came from the amino acids there, right? And then this process gets interrupted when you have liver failure. It can't do it. It says, I can do it. And they say, here's some amino acids. And out comes what? A waste product. Or sorry, comes ammonia, which is a waste product also. But out comes ammonia, which is not what we wanted. Ammonia has a charge to it. That means it's going to interact with things, right? BUN has no charge to it. It's neutral, and it can easily get excreted by the kidneys, right? So out comes ammonia, and ammonia is going to cause all of our problems. And they can make their way through the blood-brain barrier when it is leaky, like with an infection, right? So when people come in confused with cirrhosis, it's usually hepatic encephalopathy, unless it's like a severe infection, but usually it's hepatic encephalopathy. And it's because they have an infection somewhere. It could be SPP, it could be an pneumonia, it could be UTI, it could be any infection, right? So it's just a flip of the dice, or flip of the coin, flip of the dice. Anyways, roll of the dice that you have GI bleed or you have a hepatic encephalopathy. You could have both, but it's usually, the complications just depends on where they're at in their cirrhotic life cycle, okay? So all this ammonia goes in the brain, and when it gets to the brain, it crosses the blood-brain barrier, it's going to convert things. It basically makes something that is osmotically active. So now all the water goes into your brain tissue, and now you have cerebral edema, right? So which is not good. But it only got there in the first place because you had an inflammatory response because of an infection most commonly, right? So it could be a systemic inflammatory response due to trauma or pancreatitis, but it's usually an infection that we're looking at, right? Because usually there's someone somewhere that has ammonia of 200, but it's not because because their ammonia is 200 that they have the symptoms. The ammonia is because the blood-brain barrier got leaky, right? So again, BUN is formed, but that process gets interrupted, and therefore we have a rise in ammonia. Usually more than 40 points is considered a high ammonia, okay? So 65% of patients that develop this will die in 1 year.
Like a normal BUN, but increased ammonia.
Yeah, you wouldn't see a BUN elevation because you're not making BUN, right? I mean, if you have kidney failure also, yes, the BUN could go up. BUN and creatinine do go up in renal failure, but this is just like isolated hepatic encephalopathy. No, you would not have BUN rises, okay? So also with hepatic encephalopathy, you're also a fall risk, you're a driving risk, right? Even if you made it, right, out of the hospital with hepatic encephalopathy, you get discharged, 40% flip of the coin or roll the dice or flip of the dice or roll the coin, you're going to get also hepatic encephalopathy again, 40% of the time, right? So it's a downward spiral again, okay? And being in a hospital is not a clean experience, right? You get all kinds of, you can get contaminated with all kinds of stuff, right? Hospital-acquired infections, right? So what's the cause? Infection, that's the most common reason, right? And that's the pathogenesis of hepatic encephalopathy is because you have a leaky blood-brain barrier for some reason. If you had a TIPS procedure, remember we bypassed the portal circulation, went straight into the central circulation. Well, what's made? Why was that? Why is that bad? What was? Yes, we relieve the pressure, but what also did we bypass? We bypassed the liver to filter things, right? Even though it couldn't filter great, it could filter something, right? So ammonia makes its way from the portal circulation directly into the central circulation. So we have an increased ammonia level when we have a TIPS procedure done, right? So it's just bypassing, right? Where's ammonia made? It's made by an incompetent liver, but where is ammonia usually made? Not the kidneys. Where's ammonia made? Who remembers the nitrogen cycle from microbiology?
Oh, in the gut?
Yeah, in the gut by what? Bacteria, right? So bacteria make ammonia. That's where nitrogen comes from. That's how you get nitrogen into your body, is by eating amino acids or by bacteria, right? So the bacteria produce that ammonia, and then it makes its way into the circulation. It just bypasses the liver, right? Usually it would get to the liver, and the liver would then process it and turn it into BUN if it could. Okay, so hypokalemia potentiates this, in the kidneys to make more ammonia. So we want to avoid low potassiums and excessive protein. This was the thought, but it's been debated, and it's false. That for a liver patient, I got to have a low protein diet, because protein, when excess protein are broken down, look what happens. They got amino acids, and therefore they make more ammonia. But come to find out that your skeletal muscle actually breaks down ammonia naturally. So if you reduce protein intake, you don't make skeletal muscle, and you don't break down ammonia. So it's backwards. So you do want to have a protein diet. About 1 gram per kilo is on the right next page. Okay.
Would this be could you have like hepatic dialysis?
Hepatic dialysis, there's such things called hepatic dialysis, but it's really advanced. It's called Mars therapy. Mars therapy. That's where it's a liver dialysis. All right, so these are right here under increased ammonia, right? And ammonia is a waste product, right? It's like a hoarder. It's like, here, come in. Here's all my ammonia. And they're trying to go into their kitchen. It's like, okay, when did you last open the freezer? 5 years ago. Okay, all right. So then all that can then eventually get into, can leak into places when things get leaky, right? We talked about jaundice before. We talked about low albumin causing ascites. We had coag factors causing bleeding problems. We had all these things. This is one of our last complications we're talking about. There it goes. All right, so symptoms. So we mentioned asterixis before, right? So asterixis is where we have a whole bunch of asterixes, right? So asterixis is where you have the flexion of the hand, and then it's going to bounce, right? That's a sign of hepatic encephalopathy, but it could be other things. So they can stage it or grade it. So grade 4 is coma. They're not awake. Grade 1 means they're just altered, or they're forgetful, I guess you would say. And then they start getting asterixis grade 2, and then they start getting stuporous, lethargic. So those are kind of how severe it can get, right?
But you wouldn't notice it until grade 2.
Yeah, I mean, they might report like forgetfulness and such, but again, it's really with an infectious process that's causing this, right? So again, somewhere, someone's doing Sudoku with ammonia 210. That's not the issue, is the ammonia. Yes, it is, the ammonia is causing the problem, but it's the ammonia leaking across the blood-brain barrier that's causing the problem, okay? So we give medications to prevent that future state from happening, right? We don't want the ammonia to leak across. We want the ammonia to be under control. So we got to reduce the amount of ammonia. So we reduce the what? What produces ammonia? Bacteria. So we take out the bacteria that will reduce the ammonia. So how do you take out bacteria? Give an antibiotic. Or there you go, rifaximin. All right, that's usually one of the reasons it's only used nowadays is for eliminating bacteria in the gut. It's a PO, so it's just working on the gut. It's not being absorbed, and it's going to eliminate the bacteria that produce ammonia. But usually first stop is lactulose. So lactulose is used to reduce ammonia. It actually makes it very, it converts it into a basic form and converts ammonia to ammonium, which is NH4. So it just neutralizes it basically, okay? So you usually want to give this lactulose you hold it if there's more than 6 stools per day, right? So if it's 4 to 6 stools, perfect. What is diarrhea though? What's the definition of diarrhea? The WHO classification diarrhea is 3 or more stools per day. So you don't hold for diarrhea, you hold for 6 or more stools. Because if you hold for diarrhea, you're going to underdose them, right? You have to hold, you want 6 stools, and that's a hard sell to the patients. You're going to have loose stools for the rest of your life, right? So but they have to, otherwise you're going to be back in the hospital with a coma, or they're going to have more consequences, right? So lactulose, and again, if they get hospitalized again, they're probably going to be started on rifaximin the second time around, okay? If that doesn't work, we can do non-pharmacological teaching. We can tell them, hey, build up muscle, but they don't make albumin in the first place, and they have poor intake. So it's going to be hard to do that, but you want to increase it as much as possible. Put on as much muscle mass as possible. Also, remember the liver breaks down estrogen. If you have liver failure, you can't break down estrogen, therefore your testosterone is low and your estrogen is high. So you only build muscle when your testosterone is high. So it's a catch-22 in how to build muscle. But definitely you're not going to reduce whatever muscle they can produce from whatever protein they're intaking. You're not going to reduce that. That doesn't make any sense, right? So you can see ammonia and glutamate by this enzyme in the muscle is what makes glutamine, which which converts ammonia into ammonium. Okay, and BCAA, you might see that on the nutritional aisles. That's also a supplement they can take as well. Okay, so do not restrict dietary protein. Skeletal muscle metabolizes and neutralizes it. It's recommended to get 1 gram per kilo per day. All right. The last ditch effort is if you couldn't take out the bacteria, why don't you get someone else's bacteria, right? How do you get someone else's bacteria? With a fecal microbiota transplant. That's where you deposit from a stool donor, and they are in short supply. So if you want to make some quick money, right? Make sure you don't have Hep A, but also make sure that you donate some stool, and they go to a stool transplant center, and they process it. They put it in little capsules. I'm sure they wash the outside of the capsule. It has a dust when you get out of anyways, and then they take that, or they can deposit it by a colonoscopy, or they can get an NG tube and get a nice fresh dose from the lab from the stool center. It's a hard sell, but then if you're like in and out of the hospital with hepatic encephalopathy and you're going to die, you have a 60% chance of dying. It's like, I'll do anything, right? Yes, Alicia. So all right, so that's the fix. Okay, so it is option. It's an option. It's on the table. So so you're not doing that one? Okay. So okay, so lactulose, and we got here's all of our complications right here. We got hepatic encephalopathy that can occur. We got our HRS that can occur. We talked about before, ascites. And then when you have ascites, puts you at risk for SBP, right, infection, which then puts you at risk for hepatic encephalopathy. So it's all interrelated, all these complications that can occur in cirrhosis, right? So it can be difficult to get an exam for hepatorenal syndrome, for hepatic encephalopathy.
Good morning, ma'am. How are you? Huh? Oh, hello. Good morning, ma'am. Yes, hi. She seems a bit more alert than yesterday. Yeah, the lactulose must be working. Ma'am, do you know where you are right now? This state hospital? That's right. What year is it? 2022. Ma'am, can you stretch out your arms and your hands for me? No, ma'am, like this. No, you have to cock your wrists back. Imagine like you're trying to stop a bus that's coming at you. Whoa. No, not like that. Seems like you're dealing with the HE paradox. The what? HE is short for hepatic encephalopathy. No, I know that, but we need patients to fully extend their arms and dorsiflex their wrist. That will reveal a subtle flapping tremor that's caused by the excess ammonia in their blood. Yeah, I know. That's what I've been trying to get her to do. But often patients are too confused to properly follow the directions for doing the maneuver. Yeah, clearly. So then we can't confirm whether they have the tremor or not. Hence the paradox, I guess. Exactly. Maybe if she's too confused to do it, that means she must have ascites. Can't say for sure. Ma'am, let's try it again. Please hold out your arms with your wrist cocked back like this. Like this? No, like this. Why don't we just give her some more lactulose and come back later? Sounds good, Jonathan. Who's Jonathan?
All right, so hysteresis is a symptom of HE. All right, so I click the next slide, but I don't want to lose it. Let's hold on. There we go. So hepatocellular carcinoma. That's next slide, right? Yep. All right, so this is a ultimate complication of cirrhosis. So you can see down here we have a healthy liver. We get fibrosis, cirrhosis, and then we can be at risk for carcinoma. So Hep B, Hep C cause cirrhosis, and they can then lead to hepatocellular carcinoma. And you can get cirrhosis because of what else? What are other reasons you get cirrhosis? Alcohol is usually number one, right? And chronic inflammation and some other genetic issues, but all these things are leading to liver cancer. There are some ways to skip steps, right? You can eat some aflatoxins, right, like Aflac, right? No, it's aflatoxin not protect against aflatoxins. So aflatoxins are found in grains that have been moldy, right? Aflatoxin is a mold that grows, all right? Aspergillus, all right? Peanuts, soy, rice. Someone offered me peanuts earlier, so that has a liver cancer risk, right? If they are in a damp environment and they grow, that could cause aflatoxins, right? Hot, humid climates are especially at risk, so those can skip steps. Obesity, obviously going to put you at risk for every cancer. Smoking, every cancer. Alcohol, every cancer. We know alcohol itself leads to cirrhosis, so that's just going to double up, right? About 700,000 per year develop hepatocellular carcinoma, and there are other types of liver cancers, but this is the most common. It's 90% of them. And then we talked about Hep B is more virulent, so it's more virulent to cause cirrhosis and therefore cancer. But also it causes cancer more than Hep C as well. 80% of liver cancer is due to Hep B. Okay. So what else? So we got, or I think that's both of them. Sorry, Hep B and Hep C. 80% of our liver cancer is due to Hep B or Hep C, but Hep B is more common to cause it. You can get metastasis from other sites, colon being the most common. Okay, and then we have to talk about smoking obviously being a risk factor, right? And if you drink too much, that can also put you at risk, right?
This video of the squirrel in her backyard. Katie Morlock says she left some pears out for her pet pig. The squirrel grabbed a pear and ran away with it. About an hour later, the squirrel was caught on camera acting like this. She later realized the pear was in her refrigerator for a while and it may have fermented. He says that she didn't get the squirrel drunk on purpose and that the squirrel was okay. The next day it was acting normal.
All right, so alcohol use. So aflatoxins, alcoholic drinks, and the World Health Organization doesn't mess around. They call it body fatness. All right, so you got a fat body, you are at risk for HCC and many other cancers for that matter. All right, coffee is protective. Cool. All right. All right, so sugar, fat, all these things could be converted into lipids and triglycerides, and that will create a fatty liver. Alcohol itself converts into a fatty liver, but there's something called a non-alcoholic fatty liver, which is NASH or NAFLD, or it's a non-alcoholic fatty liver disease, right? So yeah, normally E2H will do it, but obesity, about 40% of adults, is really where a lot of cirrhosis is going to come from, and HCC for that matter. Right, it's from our dietary means, right? Because we'll eat anything.
I heard you, Grandma. Grandma just sent something from heaven gates above. Open the floodgates of heaven, let it rain. Cause that's what I'm going to eat next. What is this, baby? Oh, baby, no. Diabetes, heart failure, high blood pressure. Oh, baby, no. What is that? Oh, it looks good. It looks spectacular. Give me some.
All right, that's popular in America. What do they call it? Those crash cakes? What are they called? Dump cakes. Yeah. You can also make it like in a microwave, put like an Oreo and milk, and then mush it up and it makes a brownie. Anyways, America.
How do you know?
America. All right, so the symptoms of liver cancer, it's asymptomatic until it's causing problems. And maybe it might get some vague abdominal pain as the cancer starts compressing other structures. Obviously, unattended weight loss, that's every cancer, right? As the tumor is consuming all the energy and all the glucose, right? And then we'll get the cirrhotic symptoms. And usually cirrhosis can lead to liver cancer, but also it can start causing damage to the liver in of itself, right? So our goal is to see if someone's at risk. So you can do AFP, alpha fetoprotein levels, to see if there is if that's rising, they're likely to have hepatocellular carcinoma, and they have to do a liver biopsy to assess that and determine if it's spread and how much spread there is, how much dysplasia there is, right? And there's all kinds of transplant list scores you can do. You don't have to memorize these, just to recognize these are for liver. To know the different formulas and it's 3.78 times the natural log of the serum bilirubin plus 11.20 times the natural log of the INR. I do not expect you to know that. All right, that's not a math question on the test. All right, but how do you fix this? You have to take the liver out, right? You take out a piece of the liver, the infected part of the liver. You can do it from a live donor, and you just cinch off all the vessels there, and they take out a piece, left or right, and donate into the new recipient. Okay, so it's amazing. It's a very, very vascular organ, so it's really hard to preserve, and it's a really high risk surgery.